Coronary steel is a brilliant concept to break down visually as it perfectly illustrates the limits of microvascular autoregulation and explains the seemingly paradoxical effects of certain cardiac medications. Here is a breakdown of the pathophysiology and its direct clinical applications. Normally, the coronary microvasculature constantly adjusts its resistance to maintain stable blood flow over a wide range of perfusion pressures, that is, autoregulation. However, when a patient has a severe flow limiting epicardial stenosis, the arterioles distal to the blockage must fully and permanently dilate just to maintain adequate resting blood flow. In this ischemic territory, the coronary flow reserve is exhausted. The vessels cannot dilate any further. If a potent systemic vasodilator is introduced, arterioles in healthy territories, which still have their coronary flow reserve intact, dilate massively. Arteriolar resistance in these healthy zones drops significantly. Because the vessels in the diseased territory are already maxed out, they cannot match this drop in resistance. Blood takes the path of least resistance, diverting away from the ischemic zone and into the healthy tissue. The ischemic myocardium is physically robbed of its blood supply, precipitating angina or ischemic ECG changes without any actual increase in myocardial oxygen demand. The steel phenomenon isn't just a physiological curiosity, it forms the foundation of modern myocardial perfusion imaging and dictates our pharmacotherapy choices for angina. Pharmacological stress testing, MPI, PET, CMR. This is the most common intentional application of coronary steel. When patients cannot exercise, we use potent microvascular vasodilators like adenosine, regadenoson, or dipyridamole. Unlike dobutamine, which induces true demand ischemia by driving up heart rate and contractility, these agents trigger a coronary steel. By inducing maximal hyperemia in the healthy vessels, they create a stark relative perfusion defect in the territory supplied by the stenotic artery, which is then captured by the imaging tracer. Understanding steel explains why not all vasodilators relieve angina and why some may actually worsen it. Dipyridamole hydralazine. Target vessel, small resistance vessels, arterioles. Effect on ischemia worsens. Mechanism induces microvascular steel, diverting flow away from post-stenotic zones. Nitrates, target vessel, large epicardial vessels and venous capacitance. Effect on ischemia relieves. Dilates collateral channels and large arteries. Reduces preload, LVEDP, lowering wall tension without causing microvascular steel. In patients with chronic total occlusions, the myocardium often survives entirely on collateral flow from a donor artery. If the donor artery itself develops proximal disease, vasodilation causes a pressure drop distal to the new stenosis. This pressure drop at the origin of collateral network reduces the driving force across the collaterals, effectively stealing blood away from the CTO territory. Coronary subclavian steel syndrome. A macroscopic structural variation of the steel phenomenon occurs in patients who have had a CABG using the left internal mammary artery to the LAD. If the patient develops a proximal left subclavian artery stenosis, the pressure in the distal subclavian drops. When the patient exercises their left arm, the arm vessels dilate and blood flow is diverted to the arm, reducing flow to the lima, stealing blood flow away from the LAD territory to the arm. The patient presents with classic angina triggered purely by upper extremity exertion.